Please take a moment to submit any questions you may have via the chat function, and we'll do our very best to answer your questions throughout the program. I have with me a really diverse and very learned panel from both sides of the Atlantic who I'm going to ask to introduce themselves and then we'll get going. So let's first of all stay in the UK and start with Professor Sapi.
Thank you. Thank you for that kind introduction as well. So my name is Professor Liz Saper. I'm a respiratory physician and I work in acute medicine at the Queen Elizabeth Hospital in Birmingham in the UK.
Thank you very much and welcome to this. We'll then go across to the other side of the Atlantic and we'll start with Dr. Gottlieb. Robert, thank you.
Thank you, Dr. Bhagani. My name is Robert Gottlieb. I am a transplant cardiologist in Dallas, Texas. And during the pandemic, many of my patients who are immunosuppressed have been particularly vulnerable. And it's great to be in the area of the pandemic where we have evidence to inform what therapies to offer our patients to help them to recover and get back to health.
Thank you, Robert, and welcome. And also on the other side of the Atlantic and working closely at the center is Erin Duhaime. Erin, welcome and please introduce yourself. Thank you.
Thank you. Thank you so much. My name's Erin Duhaime. I'm a PA with the infectious disease team here at Baylor University Medical Center. I see COVID patients as outpatient and then inpatient and also in the ICU and the floor. So got a well-rounded view of COVID-19 at this point. Thanks for having me.
Thank you very much, Erin, and welcome to you too. So fantastic panel. Let's get on with this. I think, what is important for today is that we're going to try and focus on the management of hospitalized patients with COVID-19. And we're going to try and highlight some of the differences between the USA and Europe and look at a number of different aspects of inpatient management. So I suppose let's start with thinking about assessing COVID severity. I think what is of real interest, and we'll speak to the panel about this in a second, is that not only have we seen the virus emerge from Wuhan, spread across the world, but as RNA viruses do, it has mutated, and we have what is now called variants of concern. And there's a number of different variants of concern that have emerged from the very early days of 2020. And so I'm going to define what a variant of concern is, and then we will talk a little bit about the different variants that we've seen through the times and where we're at currently. A variant of concern is, a mutation in the virus that makes it able to disseminate across large populations of people. It becomes a variant of concern, when it either escapes immunity, which is either natural or vaccine induced, or it causes more severe disease, or it escapes therapeutics that are currently around. And so, once that starts to happen, and the WHO monitors this very, very carefully in terms of sequencing data, once that starts to happen, then a variant is labeled as a variant of concern. So I'm going to come to Elizabeth first. Elizabeth, the first variant that we saw after the virus emerged from Wuhan. So, we saw the D614G mutation as soon as the virus had come out of Wuhan. And then, in the early part of 2020, after the first wave, we saw what was called the Alpha variant, or what was described as the Kent variant. What was different in that disease?
Thank you. Well, when we knew COVID was approaching the UK, it was a period of huge worry and concern for patients, for the public, and for clinicians as well, as we didn't really know what we'd be facing, although we had an inkling it would be bad. At that time, of course, we weren't doing community testing. We didn't have the means to do that. And even in hospitals, testing results lagged considerably after patients presented to the hospital. It was very difficult to predict at that time who was going to go downhill and who wasn't, but we knew we were faced with a very variable disease, which affected some people very mildly, At that time, children in the main asymptomatic or very mild symptoms. But where I worked, we saw a considerable number of patients coming in respiratory distress with pulmonary infiltrates and high inflammatory markers that we really didn't know how to treat. And that was our experience, unfortunately, of the first wave until we started to understand a little bit more in how to look after patients.
So thank you, Liz, and this was particularly true once we got hit with the alpha variant, which appeared to spread more easily. We were seeing huge numbers of infections come through, and then we moved into the sort of beta and gamma variants, and Erin, I suppose the Americas saw a lot of the beta and gamma variants before the world went into Delta. What was your experience at the time?
Honestly, it kind of ran together. I didn't notice a big difference until Delta. Lots of people presenting to the hospital, like Dr. Saper said, high inflammatory markers. That's where I saw the ferritin and the CRPs were very high. People coming in with ADRS and needing steroids right away. So that's kind of how it went here in Dallas.
Fantastic. And we're into the end of 2022, 2023, and we're now into the sort of Omicron variant and then the sub variants of Omicron. And Robert, what's your experience of the Omicron variants and sub variants? We know that the North America is now being hit by the BA2 sub variants. Has the disease been different?
In approximately December of 2021, in the United States, we started seeing the first Omicron variants, particularly B.1.1.529, at that time appear on the scene. And there was great desire to will the virus to bend to our desires for this virus to be less virulent, less consequential. Unfortunately, within a rounding error, it's not a less virulent variant. It's not an attenuated variant. Fast forward to now when we see China starting to be exposed to the subsequent Omicron variants, we see that in an under-vaccinated, under-recovered population, it really reproduces some of the challenges that we faced here in the early phases of the pandemic. Now, fortunately, in the United States, in Europe, in most areas of the world, we have the benefit of both hard-fought recovery as well as extensive vaccination campaigns that do make the virus something that we can treat, live with, and recover for most of us. However, we do still lose some of our patients, either by chance and bad luck or genetic predispositions or other risk factors, or in rare cases because they just haven't seen the virus and have opted not to become vaccinated. Fast forward to the remainder of 2022 and going into 2023, we've gone through different variants, BA1, BA2, BA4-5, and now we're seeing the immune evasiveness of the BQ1, BQ11, and XBB variants that are really escaping from our neutralizing monoclonal antibodies. But fortunately, we have a depth of therapies, both on the outpatient side as well as on the inpatient side, to help patients recover. And vaccinations are continuing to do their job of preventing progression to hospitalization, preventing death. They are not preventing mild to moderate disease, which, quite frankly, we need to educate the public that it's okay. We want to defang the virus. We want to make it a common cold. We want to make it not a SARS virus. And that's what our hard-fought immunity from prior recovery, as well as our vaccination campaigns are doing, even as there's minor escape from our pre-existing immunity.
Thank you, and I think this is really crucial, isn't it, Robert? In other words, people talk about Omicron being a milder variant, and actually I am not sure that the virus itself has got any milder. In other words, it's affecting a population that is highly immunized and has probably been exposed in the past, as we're seeing now. And we'll see more data from China come through in the next few months, but we've already seen this in Hong Kong. this certainly isn't a milder disease in an unvaccinated, unexposed population. So we're now going to try and see if we can think a little bit about the clinical spectrum of infection. And Liz, I'm going to come back to you on this one, but this is the NIH description of the clinical spectrum. Would you mind taking us through this?
Absolutely, absolutely. I mean, of course, this is mainly used in America, although it's a reference range that we all look at. And it has a real spectrum of illness, from the asymptomatic or pre-symptomatic infection, mild, moderate, severe, and critical illness. And I think in each of the categories, as the guidelines show, it very clearly defines which group a patient might be in at that moment of time that you see them. It also provides information about the clinical tests that you might have coming back. For example, looking at lung infiltrates and severe illness, the percentage of lung infiltrates that are there, or the respiratory rate. I guess a word of caution when looking at this: it tells you where the patient is right now, and you have to put that in the context of when their infection started and what you think it might progress to become. But it does enable you to start planning management of that patient there and then, based on their symptoms, signs, and initial investigations.
So that's you make a really important point there. So this is the patient that is in front of you, and as you correctly say, you can categorize them in many different ways, and we'll look at the WHO categorization in a second as well. You can categorize them in many different ways. I suppose the big question, and this was a question that we asked ourselves right at the beginning, is how are we going to predict, who's going to progress through that spectrum to become critically unwell, so that we can intervene early. Robert, any thoughts on this?
So yes, I think that early in the pandemic, when we were designing clinical trials, we all assumed that inflammatory markers would help us predict who would progress on. However, it's been a humbling exercise, and I would say the inflammatory markers do not allow us to predict as well as we would have hoped. It doesn't allow us to discretely bin. There are some patients that have lower inflammatory markers that still relatively progress. And concomitantly, our therapies that we know that can help intervene also modify these inflammatory markers. Now, that is a beneficial consequence. We'll hear Dr. Saper talk about corticosteroids and other immunomodulatory agents that have really changed the spectrum. But I would say one of the things that as a global community, we've learned a lot about how to cooperate across borders, across barriers, but we've also been very humbled by some of our predictions that have not held fruit as much as we thought, and the inflammatory markers have not been as strong of a predictor, especially for predicting clinical trial outcomes, as we would have expected.
So, for me, one of the interesting things was that we learned very early on about patient-related factors that could help predict progression. In other words, older, comorbidities. There was some question about race in the UK as well. And so this became really important factors. But what we couldn't do is, once that patient had presented to a hospital, we couldn't say who was going to progress or not. I know that in the UK we looked at a number of scoring systems that might help us predict that, and yes, useful, but not 100% accurate in terms of deciding at the front door which of these patients was going to get sick. There is some interest of late looking at plasma levels of antigen, and this is becoming maybe one of the biomarkers that we may be able to think about in the future, in terms of trying to risk stratify people as they're being hospitalized, because we can risk stratify people in terms of being hospitalized, but once they're hospitalized, this becomes a little bit more difficult. So I suppose one of the key issues, and this became a real story at the time, Aaron, was the use of pulse oximetry. What's your experience around pulse oximetry, and how useful was that, both in the community and once patient got into hospital?
Community, when COVID first hit, nobody had a pulse oximeter at home at all. And so you did have to, my higher risk patients in clinic as outpatient, I would, recommend that they pick one up. They're not sick yet. If you do get sick, you have it. And so those were actually flying off the shelves here. People were saying they couldn't find them. So it was helpful if they had a pulse oximeter. If they didn't have it, then it wasn't very helpful. I had to kind of go on their clinical presenting symptoms and send them to the ER to be evaluated. In the ER, I think we meet most of our patients, our COVID positive patients, in the ER. And I think the capacity, it was over capacity. We had patients in hallways. Nurses in the ER were not able to document pulse ox, completely. So you'd see things that were kind of worrisome, but then you'd see the patient and clinically they were doing great, or opposite. And so it is helpful, but again, kind of just what Dr. Saper said, it's right then and there. It's giving you information right then on the oxygen status, but there's lots of things that that can be affected. Skin pigmentation, fingernail polish, if they have poor circulation, those can affect those results. So we weren't going just by pulse ox. We were also obviously looking at labs, imaging, and how they were presenting and clinically looked.
Thank you, Aaron, and that's really useful, and there's some really useful pointers in there. And so, the WHO actually took a step back and said, look, let's try and make this as easy as we can, because remember, this is a global problem. Not everybody has access to arterial blood gases to do your FP ratios, etc. And so let's just divide disease into non-severe, severe, and critical, and this is what the WHO definitions look like, and these are very useful because it helps us classify patients in terms of responses in clinical trials. But I think we all understand the severity of the disease and what it looks like. So Robert, just a brief kind of look at what your initial evaluation would entail?
So I think that one of the points that we were just discussing, pulse oximetry, is really critical, because although there is the discrepancy between the WHO and the NIH scales, it's important to note that this is a SARS virus, and the SARS virus demands a slightly different treatment than some of our other respiratory viruses. For example, we in the United States have utilization review requirements that traditionally say, why are you admitting a patient to a hospital for a viral pneumonia if their oxygen level is not less than 88%? And I think one of the things that the NIH guideline and naming convention for disease severity demonstrates is this is a different respiratory virus, and that patients may be at risk even with a higher oxygen saturation level. We all see routinely that a patient may, for example, have a oxygen saturation of 95%. But if you road test them in the emergency room, you may see that just going across the room, they may easily desaturate to the 70s, and they may not even perceive that dyspnea. So I would say one of the things to ask is not just what is the oxygen level by plethysmography, but also what happens when you have that patient exert very gently, even with activities of daily living, getting across the room. And it's okay to hospitalize a patient with an oxygen level that is far greater than 88%, or just because you're worried about that patient. The initial assessment varies depending on where you're at and depending on infection control processes. In the United States, we've been very heavy into just plain film radiography. It's actually been a renaissance of very simple techniques rather than using high technology. The number of CAT scans in the United States, computed tomography, has decreased dramatically, whereas in other parts of the world, we've actually paradoxically seen an increase. It's of course important to take a survey of hematologic parameters. We know that neutrophilia and lymphopenia are both predictors of hospitalization. My transplant patients have a lymphopenia that may be intrinsic and actually needs to be thought of a little differently, because the lymphopenia of transplant doesn't necessarily equate to the same risk that lymphopenia would otherwise equate to, but more progressive lymphopenia certainly does predict a higher risk. Of course, the basic metabolic profile, creatinine, renal function, it dictates the risk. We see that patients with comorbidities, especially renal dysfunction, are at higher risk of both hospitalization and adverse outcomes up to and including death. We've seen that time and time again. Or we might find that we have patients with acute renal failure because they might either early in the pandemic have nausea, vomiting, and diarrhea and losses, or they might just have a SIR state and be very inflammatory. We've also seen that the albumin, particularly the decline in albumin over time, may predict who's more inflammatory and may progress. And of course, nothing replaces clinical judgment. We've also seen that D-dimer, that we usually think of as a dichotomous yes-no, positive, negative, for risk of needing a CAT scan, potentially if you're worried about pulmonary embolism. In this case, we see that yes, COVID increases the risk of pulmonary embolism, but the D-dimer is almost universally elevated in patients hospitalized, even in the absence of pulmonary embolism. And so certainly the D-dimer has had a renaissance in predicting who is inflamed in addition to that CRP that we were talking about. And each of these needs to be put in context. And ultimately, clinicians that have treated multiple COVID-19 patients probably have a better sense at clinical bedside as who's going to be at risk for progression.
Liz, I'm just going to bring you in very briefly around this. In the UK, one of the things that we were particularly keen on using was a clinical frailty score, because we saw a lot of elderly patients. What's your experience with this?
Yeah, so it was information that we were collecting in older patients. We weren't using it in younger patients or those with stable long-term disabilities, because we know that it isn't effective there. But to give us an indication of the likely response that people may have to treatments, as well as their clinical course. And this is really important, because I agree with everything Robert said in terms of how we would evaluate patients. But to add to that, that you need to make a judgment, not only what care do patients need now in terms of COVID, but that holistic approach about what therapies would meet their expectations, which are likely to be beneficial or futile, and how can you care for that patient, thinking about them in their entirety as opposed to just trying to stratify the virus. So the CSF scale was really helpful in terms of prognostication, but also gave you an indication of duration of admission, maybe ceilings of treatment if you thought a patient may not be suitable for invasive ventilation, if you thought that might be a futile treatment for them that may cause more upset rather than any benefits, and in order to think about the different specialisms that might be needed to come in and look after those patients as well.
Yeah, and that's really crucial, isn't it? And you know, we used a lot of this in you know, health services were really tight, and you know, we were making sure that people got their appropriate services to their needs, and so this was really helpful. We're going to move on to kind of think a little bit about identifying patients at higher risk of progression to severe COVID-19. Erin, do you want to take us through some of the factors that came through very early on in terms of identifying who's likely to progress to severe disease?
Yeah, you know, early on we were, again, didn't really know a lot about risk factors, so it was something we learned as we went. Here in Dallas, we actually saw obesity as a significant risk factor here, not just diabetes, just, you know, hypertension and obesity, and they would, you know, at high risk. But since you know, with the evolution of this pandemic, and we're learning a lot, patients who are 65 or older, so just age is a risk factor. Any underlying conditions, well, not any, but underlying conditions such as asthma, diabetes, I mentioned obesity, untreated or advanced HIV infection and AIDS, any cancer that's going on, and especially if they are on chemotherapy or anything that would affect their immune system and make them immunocompromised, cardiovascular disease, chronic kidney disease, liver disease, a chronic lung disease, and cigarette smoking. And obviously patients like Dr. Gottlieb's that are transplant patients and are on immunosuppressive therapy.
Thanks, Aaron, and that's really, really useful. And this still stands even now, that these are kind of the risk factors associated with progression. Liz, just to bring you in very quickly, in the UK, we have kind of identified a subset who are at highest risk, who get the sort of outpatient therapies via the COVID medicines dispensing units. Just a brief summary of those.
Of course. So it's patients with one or more risk factor, beautifully outlined, really, I think, by Erin. So those that we know have got significant comorbidities or are immunosuppressed, or we think are unlikely to have mounted a good response to the vaccine program. And there, if we think that patients are at risk of progression, there is a treatment pathway that enables you to provide therapies to try and prevent that progression.
So, I just to explain the natural history of COVID-19 in a pathophysiological manner. So this is something that we learned quite early on. We think there is, the early stage of infection where there is lots of viral replication. The immune response kicks in with an antiviral response, and if you're successful, you go on to resolve symptoms, and everything is fine. Sometimes, the viral replication continues despite the immune response, and it starts to cause, your pneumonitis and multi-organ inflammation, and this then in a small subset of patients can progress to a hyperinflammatory response where the immune response has not been successful in clearing the virus completely. The immune response has gone out of control. And these are the patients that often end up in hospital and on your intensive care unit. We've also learned that your interferon responses are really crucial in this. This is the part of your innate immune response that kicks in very early on in infection. And if there is a delayed type 1 or type 3 interferon response, then this kind of precludes an adaptive response and precludes viral replication control very early on, and so then leads to an inflammatory response that includes a huge number of inflammatory mediators and cells that are involved in this, and eventually leads to endothelial activation and thromboembolism as well. So when we think about therapeutics and intervention, then one needs to think about therapeutics in two different ways. You think about preventing viral infection, you think about early interventions with antiviral agents, and then as the immune response has gone out of control, you then think about immunomodulator therapy. And there's a huge overlap between these different phases, and so we need to try and work out what therapies are best for people at what stage. We know that the best prevention clearly is vaccine, and there's beyond any reasonable doubt really good data out there now to suggest that vaccination, even if it doesn't completely prevent infection, will prevent severe disease and severe outcomes. And so that's the best prevention. But there are people and a lot of immunosuppressed patients out there who are not able to mount an antibody response to vaccines. And for that, the preventative therapy and monoclonal antibodies is probably the only thing that's been tried so far and has been successful. Although, as the variants evolve, they're escaping the currently available monoclonal antibodies. But that seems to be a good way forward. We will look at studies in the very near future, which will think about antivirals, at least in the post-exposure type setting. Then you look at early intervention for the group that Erin and Liz talked about. So these are people at high risk of progression, even though they don't have symptoms at that stage. And early intervention in that group of patients may be very, very useful. We have got some data, at least in terms of antivirals, that worked and were useful in terms of preventing hospitalization or death. And we won't look at this data in detail today, but there is data out there. And then as people get into hospital, things start to change. You if they're early, then antivirals may be really useful, and we'll talk about remdesivir in a second as an intervention in early hospitalization. And as that people get sicker and into the more hyperinflammatory phase of disease, then immunosuppression or immunomodulator therapies will become more important. So that's a kind of brief overview of therapeutics. But what we would now like to do is to start looking at some of the guidelines and looking at some of the specific issues. So I'm going to first of all go to Liz, and we'll talk about NICE. Now, the UK have NICE, which not only makes guidelines but also decides on cost effectiveness of therapy. So please walk us through this, Liz. Thank you.
Yeah, absolutely. So the first thing I would say about this slide is if you look at the no oxygen support early COVID-19, but at high risk of progression, in July, the guidelines were still suggesting neutralizing monoclonal antibodies. And we know that these are not as effective against the newer variants that we've seen as they were against the Delta variant. And so I think this slide shows how quickly COVID guidelines go out of date. And that would be maybe a take-home message to talk about later. You always need to make sure that you're looking at the most up-to-date guideline. So we won't talk about no oxygen support, that group of patients at high risk of progression on this slide. And instead, we'll look at the low flow oxygen and the high flow oxygen, CPAP or mechanical ventilation component. And you can see that the NICE guidelines recommend corticosteroids across that group requiring oxygen, no matter whether they have a low oxygen requirement, high, or indeed need ventilatory support. And then you can see the use of the IL-6 antagonists, and then coming in the JAK kinase inhibitors as well, with low molecular weight heparin at a standard prophylactic dose being recommended as well because of that increased risk of venous thrombotic events that we were seeing. And then you have conditional use of other medications coming down the line with treatments that were less readily available at that time. But again, looking at your antivirals with remdesivir being there, looking at your JAK kinase inhibitors and the other the anti-IL-6 that we have available. What I wanted to go through in a bit more detail is how the policy for looking after patients who are not requiring oxygen but are at a higher risk of progression and what their management looks like in the UK now. And this is the policy update that came out in November of last year now, looking at what our first line, second line and third line treatments are. And you can see that there's a really helpful flow diagram, which you can go through in your own time when looking at these slides, but you can see that the neutralizing monoclonal antibodies have disappeared from that component of the guideline now. And we're really focusing on the early identification of patients at risk, understanding which treatment might be the most suitable for them, thinking about the comorbidities they have and contraindications to therapies, but really utilizing our antivirals here. And the recommendations are to use them early in those patients who are at risk. And we have a first line, second line and third line choice outlined by NICE, as you can see. There are also therapies which are now recommended only in research, and these are for some pediatric treatments such as the tocilizumab for children and young people, and also therapies that have shown an interesting signal in early research studies, but where NICE feels more evidence is required and they should only be utilised as part of a research study. That includes budesonide, an inhaled corticosteroid, following signals of benefit in a clinical trial that came out of the UK, and also the use of remdesivir in high flow oxygen therapy, and the idea of using intermediate or treatment dose enoxaparin in in COVID-19. So these are where NICE is saying these shouldn't be utilised as part of standard clinical care, and you should be only using them as part of a clinical trial. And then there are therapies that have not been recommended, that are very clearly you're asked not to use them in the settings as given, because NICE has evaluated the evidence and found it to either have a poor quality, low evidence of efficacy, or poor cost effectiveness.
Thank you, Liz. That's really fantastic, and I think that's a great summary of what we actually do in the UK. So the one agent that seems to cause controversy in hospitalized patients is remdesivir or antivirals as a group. In other words, by the time people get into hospital, we think they're probably at the end of that viral replication phase, and the hyperinflammatory immune system has kicked in, and the question always becomes, do antivirals have an effect in that population? So Robert, I'm going to come back to you around this, because I think this is really important. We have some clinical trials, some randomized control trials, but we also have real world evidence that has looked at this. And would you mind taking us through some of that? Because in the UK, it's only conditionally approved by NICE.
So I'd like to discuss some real-world evidence that we've collected over the course of the pandemic. If we think back to the early phases of the pandemic, we had to work stepwise to garner this evidence, first starting with randomized controlled trials. And the pivotal trial was Act 1, early in the pandemic, prior to the advent of corticosteroids and the evidence basis for that. And this was international, well-run, well-conducted. And we showed there was a decreased time to clinical recovery, particularly for patients on non-invasive mechanical ventilation that hadn't progressed to that point yet. So particularly for patients on low flow, as well as early phases of high flow oxygen support. That being said, it would be always natural to ask, well, wouldn't it be better to treat earlier? So for example, before patients get to that phase. And then the second question is, what about mortality? Act 1 has been cited in terms of mortality as showing an absence of mortality, but that's really not what it showed, because it was never powered to ask the question of mortality. You can't ask a trial to demonstrate a mortality benefit when it's not powered for that. What you need to do is you need to develop the early evidence. We showed that it decreased time to clinical recovery, and then subsequent to randomized controlled trials, develop real-world evidence to see those other markers that are so critically important, such as mortality. And this is what we're showing here. We've done two different analyses with very large clinical databases in the United States. This slide is demonstrating the Health Verity ecosystem with a JAMA Network open paper that was just published on the 1st of December. And what we showed was across the levels of oxygenation support, including up until ECMO and invasive mechanical ventilation, surprisingly, that there was a mortality benefit. And we did multiple different sensitivity analyses looking at to prevent differential censoring. And long and the short of it is, in multiple different methodologies, in multiple different ecosystems of data, we are showing a trend and a demonstration of statistical benefit in decreasing mortality. And in fact, even the Solidarity trial, where it had a preliminary report that was, quite frankly, preliminary, the final report also showed a 13% mortality benefit for patients that had not yet progressed to mechanical ventilation. So these all corroborate that, yes, antivirals can decrease mortality. I think it's also important that in real-world settings, we think about that we're not talking about a clinical trial setting. We're not talking about populations per se, but we're trying to treat the patient in front of us. So that allows the clinician to make an individualized decision. For example, in the real world, a patient might be on invasive mechanical ventilation, not because of COVID, but for a different reason, and might incidentally have COVID, and they should not be deprived of early interventions. For example, if a patient was driving along today, free breathing, had trauma, and ends up on a ventilator, that does not place them at a higher ordinal scale. Rather, you should impute the ordinal scale or the severity scale where they're at, meet the patient where they're at, and start the intervention. As we're going to talk about later, we've incrementally also gathered the data that earlier use of antivirals is more effective. Of course, we have to look at different outcomes. We're no longer looking at mortality when we start treating early. We're actually looking at prevention of hospitalizations. So we have to tailor the question at hand.
Thank you, Robert. That's really useful. So the take-home message there is that antivirals may still have a role to play in hospitalized patients, especially in early hospitalized patients. And then there's that subgroup of patients that you look after who are immunocompromised, where viral replication may be a key driver to the morbidity and mortality, where antivirals may be particularly useful. I suppose we ought to think a little bit about corticosteroids. Erin, I'm going to bring you into this just for the moment because it's if one of the things that we've learned from COVID-19, the single most important life-saving intervention has been corticosteroids, and I wondered whether you might want to talk a little bit about the recovery trial and dexamethasone use in hospitalized patients with COVID-19.
Yeah, absolutely. So the recovery trial was open label, and it was randomized controlled, and it was looking at using dexamethasone in hospitalized patients with COVID-19. And they looked at patients who also, were at room air, and they looked at patients that were on low flow oxygen and also patients that were on mechanical ventilation. Basically, the take home is that in hospitalized patients with severe COVID-19 who required supplemental oxygen, dexamethasone reduced mortality at 28 days. And the greatest benefit was seen in those receiving mechanical ventilation at randomization. There was no survival benefit for dexamethasone in patients who did not require supplemental oxygen at randomization.
Erin, I think that's a great point. Because if we go back to the early phases of the pandemic, primary care providers in the outpatient setting wanted to be able to help a patient. And one of the things that all physicians have, all providers have to offer is an investment in caring for the patient and sharing that relationship and walking along with the patient. And some well-intentioned individuals have prescribed corticosteroids in the outpatient setting, thinking that would be helpful. And what we've learned is, as this group well knows, the early use of corticosteroids in the outpatient setting or even in the inpatient setting prior to the need for oxygen supplementation is actually harmful, certainly in the outpatient setting, actually even increasing the risk of progression to hospitalization. And so it's so critical that the audience recognize that this very same therapy that is so beneficial when patients are hospitalized with hypoxemia due to severe or critical COVID-19 is actually harmful in the outpatient setting. And you can do the best for your patient by withholding those corticosteroids unless there's an independent reason that those patients need to be on a corticosteroid.
Yeah, and if I can come in actually, Robert, just to add to that really important point, it's also very important to think about the results of the high-dose dexamethasone study that Recovery went on to do, that actually showed in patients with hypoxia and either no oxygen requirements or simple oxygen requirements, increasing that dose to 20 milligrams of dex was also associated with poorer outcomes for patients, including increased episodes of pneumonia. So too much of something that works at a certain dose, just giving more of a therapy might not be beneficial. And the high-dose recovery study suggested that it could be harmful in those patients requiring simple oxygen therapy or no oxygen therapy. So it's important to know, as with all therapies, when you need to deploy them and make sure that you get the dose right based on the studies and the evidence that's out there.
Thank you, and those are both really important points. So my understanding is that the high dose dexamethasone, at least on the intensive care unit and people that are requiring ventilatory support, is still ongoing. But the high dose dexamethasone has been stopped for those not on the intensive care unit. And we saw, when India went through the Delta pandemic, or we saw huge numbers of cases of mucormycosis as a result of very high doses of dexamethasone. So in endemic countries, not only is there an issue, with bacterial infections, but you might see fungal infections as well, especially in high risk people. Okay, I suppose we've talked about two of the key issues in terms of therapeutics, corticosteroids and antivirals, at least in terms of remdesivir. Erin, one last question in terms of IL-6 therapies. So we've seen all the data around tocilizumab and how effective it is in terms of the sicker end of the scale of patients. So both of the intensive care unit and those requiring oxygen and with high inflammatory markers. I suppose a question that I often get asked is there long-term issues with a single dose of IL-6 inhibition in terms of infection risks?
I think that's hard question to answer, in particular because these patients are also being treated with corticosteroids at the same time, and prolonged courses in some cases, so we did see some. We did not see any mucor, but we did see fungal, infections in the lungs. We saw lots of bacterial secondary infections. But I think that it is definitely possible, and it's just hard to kind of weed out because you're using toci with high dose corticosteroids.
I think it's also interesting to point out that the immunomodulatory agents of, for example, tocilizumab and baricitinib are often spoken of in the same sentence. But it's also important to note that there's a lot more equanimity in some of the tocilizumab data than there is in the baricitinib JAK-STAT inhibition, where at least to my knowledge, the trials have universally been favorable, whereas there are some equivocal or negative trials in the tocilizumab space. So I would predict that 5 years from now, we're going to look back at this and we're going to add more nuance, and we're no longer going to be talking about immunomodulatory agents, but we'll be focusing more on the mechanism of action as well.
Yeah, important point, Robert. But remember the WHO guidance actually says you could use both of those together. In other words, they're different modes of activity, and so maybe different in the way that they prevent inflammation. But these are important questions that we will answer, I think, in the next few months. We've already seen some data, long-term 90-day data in terms of tocilizumab from the REMAP-CAP trial that suggested there weren't any problems with reactivation of tuberculosis, etc. So I think single doses are probably reasonably safe, and short courses of baricitinib are probably reasonably safe. I think we're nearly coming to the end now, and so I'm going to come back to each of you, and we're going to start thinking about take-home messages for 3 different sorts of patients. So we'll start with you, Erin, in terms of your pre-hospitalization patient. What are the key things that we need to do to prevent hospitalization and prevent death?
So I would say a couple different things. Education obviously is very important. Promoting and recommending immunizations is very important. And just the education and giving them some data behind those recommendations to make sure that our community is as well vaccinated as possible. Patients that are clinic patients for other things like my HIV patients, helping them to understand their risk and the importance of compliance with their HIV medications, for example, or glycemic control in my diabetics. I think that that's important for them to know their risks so that if they do develop symptoms, they know who to reach out to. They can get a hold of me, my office 24/7. They know what signs and symptoms they're looking for, and they know their risk so that they know how important it is to get a hold of me. Also, once they have, in the US, we have given free testing, just antigen testing out. And so a lot of my patients, I make sure that they have tests at home. and that they can run those tests and they know to do them back to back if the first one's negative, and making sure they're communicating with us. If they do come back positive or suspect they're positive, the first test is negative, but they're symptomatic, education on knowing where to send them, and I say that because we have an infusion center here in my office, so we can do some of the infusions as treatment, but using some of the prescription medications and looking at their medication list for drug interactions is also very important.
Thank you, Erin. And so, you're right. So there are key interventions on there that we can use for high risk groups of people, but who need to be aware that there are interventions available. And these are particularly around antivirals like nirmatrelvir and molnupiravir, remdesivir. Robert, so once a patient's hospitalized and they're becoming progressively unwell, starting to require oxygen, what are the key interventions at this stage?
While I know that the focus right now is on treatment of the hospitalized patient, I think it's also important to put this in the context of the pre-hospital outpatient therapies, because as the pandemic wears on, you are more likely to experience a patient that also might be in the hospital for a different reason and might incidentally have COVID-19 that also warrants therapy to avoid having more issues at the same time. So in that context, I'd like to spend one moment talking about early intervention with antivirals. And this is in the pre-hospital setting that informs what to do in the hospital as well. In the pre-hospital setting, we have multiple different types of highly effective antivirals of different classes. You had mentioned, for example, after the Delta variant had progressed onto Omicron, in the UK, neutralizing monoclonal antibodies had waned in their usage. In the United States, I was fortunate to have access to neutralizing monoclonal antibodies that maintained efficacy, including some new ones that came online, such as bebtelovimab that was specific to the United States. And that maintained efficacy all the way through BA1, BA2, BA4-5, and only escaped when BQ1 and BQ11 and XBB arrived on the scene more recently. But in totality, when we look at all of the trials of effective neutralizing monoclonal antibodies for which the variants in circulation have susceptibility, we've seen, independent of manufacturer, they all reinforce that the early use of a macromolecular antiviral, a neutralizing monoclonal antibody, decreases progression to hospitalization in patients with one or more risk factors. Similarly, we have the outpatient therapy of ritonavir-boosted nirmatrelvir. And in fact, if you look at the Kaplan-Meier curves of progression to hospitalization, other than changes in the magnitude, the shape and time of differentiation of the curves of treated and untreated with antiviral, they all separate around the same time, and they all are reminiscent and reinforce this concept that an early use of an antiviral is effective. Now, we also have this situation of a parenteral therapy of remdesivir that can be used both in the outpatient setting as well as in the inpatient setting. And the Pine Tree data that you'll see here demonstrates that the early use of 3 days of remdesivir, 200 milligrams on day 1, and then 100 milligrams on day 2 and 3, can prevent progression to hospitalization and decrease hospitalizations by 87% in patients with one or more risk factors for progression when used early within 7 days of first symptom, and in the trial within 4 days of the first positive test. Fast forward to the hospitalized setting, if a patient happens to be coming in for a procedure and is incidentally found to have COVID-19, I'm also going to use those outpatient guidelines to treat that patient that is now presenting to me in the hospital, because it just doesn't make sense to let my patient progress before I start treating them. The biggest barrier to use of remdesivir is the lack of IV access in the outpatient setting. And if a patient's sitting in front of me with that IV in the hospital, I'm going to try to protect them and get them the treatment that they need. Lastly, I've excluded discussion of other antivirals that I would actually classify as viral mutagens, such as molnupiravir, because that's a different mechanism of action and beyond the scope here. And I think there's concerns about efficacy and public health safety of molnupiravir, at least in some corners of the community.
Thank you. So we're going to move lastly on to Liz. And so Liz, despite Robert's best efforts, the patient's disease has progressed and they're now onto high flow nasal oxygen and probably will soon require mechanical ventilation and possibly some pressor support. What next?
Yes, well, I mean, the first thing to say is if I fall unwell with COVID-19 and I'm hospitalised, can I please be admitted under Robert's care in his hospital? Because that sounds like exemplary management in my mind. By the time patients have gone to the intensive care unit, it's a different game now. They have progressed, they're critically unwell, and they're at high risk of death. And even if they survive, there are likely to be long-term consequences for their period of time on the intensive care unit. So now it's about using anything you can in order to reduce inflammation and to mitigate the risk of death as much as possible. So when you get to this stage, I think the equation about risk versus benefits of treatment changes somewhat. Because the patient is already critically unwell, you certainly don't want to make that worse, but you want to give them every chance of survival from this, what can be devastating disease. And actually here, most of the guidelines agree on the use of dexamethasone, certainly, on the use of an IL-6 antagonist, usually tocilizumab, and the use of baricitinib as well, and potentially the use of all three of those therapies if people aren't responding and appear to be progressing despite that. Of course, those therapies are not the only tools that we have. We also know more now about the optimal management of patients on the intensive care unit with COVID-19. And again, this should be a holistic effort to think about the patient in their entirety, looking for risks of things such as acute kidney injury, looking at the potential for secondary infections, which we know some of these patients get, and trying to optimize their oxygenation. So it really then does become a multidisciplinary approach to caring for those patients, to help them through, if they hopefully survive, that long road often to full recovery.
Fabulous. Okay, so that brings us to the end of our discussions for today. Before we finish, I'm going to go back to the wonderfully learned panel that we have with us today and ask them all for a one-line concluding remark for today. So let's start with Aaron.
Okay. I'd say the take home for me would be collaboration, collaboration, collaboration. Your colleagues are all working hard. We've all got the same goal. Make sure you're communicating with each other. And secondly, make sure you're staying on top of your circulating variants, and that's going to help all of us figure out what kind of therapeutics will help your patient.
Thank you. Robert.
Once a patient is hospitalized for COVID-19, regardless of risk factors on paper, they've shown manifest risk, and I would start early use of an antiviral therapy, regardless of whether they're not yet on oxygen or whether they're on nasal cannula or high flow nasal cannula oxygen. And I would impute a surrogate for their COVID-19 severity, and I will not deprive a patient that's on mechanical ventilation for another reason from access to an antiviral therapy.
Thank you. Liz, finally.
Yes, hard to follow those, isn't it? But I think I would say that COVID-19 remains a nasty disease associated with a lot of deaths. We're so fortunate now to have a number of different tools and approaches we can use to look after patients. And my take-home message is don't be complacent. Use the therapies we've got. Let's try and protect and save lives.
This brings us to the end of our program. Please be sure to visit us at peerview.com/COVID-19 in order to access the enduring activity format and all of the excellent resources that we're making available through this program. Please be sure to download the activity slides and practice aids, which include additional information on recent and ongoing clinical trials for patients with COVID-19. We will rebroadcast this event on January 31st. Watch for the online activity launching in the coming weeks. Thanks again to Peer Review for making this CME program available and Gilead Sciences for providing the educational grant for this virtual symposium. And thank you for joining us. We hope that this activity will have a positive impact on your practice.